Today I'm going to speak here on tyrosine kinase inhibitors and thyroid cancer, special emphasis on complications. I'm a medical oncologist, so mainly dealing with medical complications of how we deal whenever a patient is referred for systemic therapy. So I will be speaking on these broad outlines. A small introduction to thyroid cancer, and in what histologies and approvals that we treat as medical oncologists, the metastatic approvals of tyrosine kinase inhibitors, and the topic of emphasis here, the tyrosine kinase inhibitor toxicities. So this becomes relevant to us because all of us know medical oncology especially has now moved into molecular front, and this in thyroid cancer is specifically seen with different histologies. So whenever we talk about types of thyroid cancers, there are differentiated thyroid cancers which are epithelial cell derived. We have papillary, follicular, and the oncocytic or the Hürthle cell carcinoma, the medullary, and anaplastic. Each of these originate from particular cell, and they also have different molecular biologies of which are druggable targets for us. So in this slide, we try to tell you how the epithelial follicular cells have a different molecular biology, and the parafollicular cells which cause medullary thyroid carcinoma have a different biology. So whenever we talk about epithelial follicular cells, we have papillary thyroid cancer. The most common is follicular thyroid cancer, and then the Hürthle cell variant. So if you see the papillary and the follicular thyroid cancer, the molecular pathways are the same. Whenever we talk about these molecular pathways, it can be either a primary event or a secondary event. Secondary event is something that they gain towards as they progress towards loss of radioiodine uptake as well. So initial markers, whatever we see, are activation of BRAF pathway, RAS mutations, RET fusions, NTRK fusions, and the ALK rearrangements, which are more common for both the papillary and the follicular. And then they move towards polydifferentiated thyroid cancer. We all know that TP53 is an acquired mutation in most of the cancers and determines a very poor prognosis. So these epithelial thyroid cancers can also progress to anaplastic, or we can directly have a very poor presentation of anaplastic thyroid cancer from the epithelial cell origin. We then have the parafollicular C cells, which give rise to the medullary thyroid cancer. Here we have the specific molecular pathway, that is activation of RET. Again, we have, whenever I am emphasizing on these molecular pathways, it is so because each of these molecular pathways can be targeted. So when we are referred to systemic therapy by the surgeons, that is usually in this set of indications. So the most commonest referral for us is a radioiodine refractory setting. This is more so important for us is when we treat what patients are referred to us and when we have indications to treat. So in this radioiodine refractory setting, it can be either a locally recurrent or an advanced thyroid cancer or a metastatic cancer. In this also we have caveats on when we treat. This I will deal with in detail in the next slides. The second and a very rare indication is in a neoadjuvant systemic therapy, as a neoadjuvant systemic therapy in unresectable disease. So some in rare cases, especially in anaplastic thyroid variant, they can either present with rapid progression or visceral invasive disease. And in such cases, if the surgeon deems that the surgery is very important and can be resected with some amount of systemic therapy, that is when we give them tyrosine kinase inhibitor. Again, we have to do a targeted approach for them, reassess after 6 to 12 weeks for resectability, because we all know surgery is one of the most important therapy for thyroid cancer. So this is the same which is emphasized on our NCCN guidelines, a recent version 4.2024, where locally recurrent, advanced or metastatic not amenable to radioiodine therapy. So whenever we get, this is the same for both the epithelial histologies, the papillary and the follicular, we have to test for these alterations, the ALK, NTRK, BRAF, RET, and also for immunotherapy related molecular markers, the MMR, MSI, and the TND, because we all have all these targeted drugs which are available when such mutations are there. So this is the same for follicular thyroid carcinoma as well. So as I told you, the medullary carcinoma has a different molecular biology. So we have this the hereditary and the sporadic variant. The hereditary almost always has RET fusions or RET mutations positive. So they have specific targeted drugs, the selpercatinib and pralsetinib, which are approved for RET fusions. And we have the general RET fusion multi-tyrosine kinase inhibitors as well. So in a medullary thyroid cancer, this is what the testing is recommended whenever they are referred to for systemic therapy. So anaplastic behaves quite aggressively, more so whenever we talk about anaplastic thyroid cancer. This is one of the dreaded cancers, and most of them present with stage 4A or 4B. 4A or 4B means they are loco-regionally advanced. So whenever it comes to this, there is a small subset when and most of these subsets are not amenable for surgery. So if we have to give a chance for surgery, which is also not so common that they convert to surgery. So we have to check for these mutations, especially the most commonest molecular aberrations that we see in anaplastic thyroid cancer is BRAF mutations, particularly V600E type. So we need to check for these mutations. If possible, do a therapy directed against BRAF V600E or target with a multi-tyrosine kinase inhibitor. So this is for borderline resectable. So this again is important for, I think, surgeons would know. This is in the interest of the students. So how do we generally treat a thyroid cancer? So initially it is surgery and surgery alone, which occupies the most important place in the cure or the management of thyroid cancer, followed by TSH suppression and the radioiodine therapy in radioiodine sensitive differentiated thyroid cancers. So later on what happens, patient is on observation. So when on observation, they can either remain in remission or they can present with metastasis. So whenever a patient presents with metastasis, what is important is when to treat. So there can be indolent metastasis. Indolent in the sense they are not symptomatic, they have some lung nodules, they have some bone metastasis, they do not have any symptoms related to that. So such patients can still be observed. They need not be immediately offered systemic therapy. So again, when they present with metastasis, we have to again follow up with the same arms. We need to step up our TSH suppression. We need to do a radioiodine study and see whether they are still radioiodine uptake positive. If they're positive, again a chance of radioiodine ablation can be offered. And there are some local therapies, like if they present with local recurrence, we can offer local tumor bed recurrence or nodal recurrence where the surgery is possible, external beam radiation, cryoablation or embolization. These local therapies can be offered. In bone metastasis, for to reduce the skeletal related events, we can talk about bone modifying or remodeling drugs like zoledronate or denosumab. And in this kind of setting where it is radioiodine refractory or it is clinically significant progressive disease with symptomatic or threatening organ function, that is when the role of tyrosine kinase inhibitors come. So in that we have to do an NGS testing. We can either do it on the initial biopsy block or ideally in a recurrent case, if the recurrent disease is amenable for a rebiopsy, it is always best to have a repeat tissue biopsy to look for molecular evolution and then plan the targeted therapy accordingly. So now coming to the drugs which are approved, so we have all these drugs in our armamentarium and many more as well. So initially it started with vandatanib in 2011, then came lenvatinib in 2015. Lenvatinib is the most favored drug by all our medical oncologists, more so because of its easy availability. I wouldn't call manageable toxicities, it has significant toxicity. But again, it is like a poor man's tyrosine kinase inhibitor, irrespective of availability for NGS testing or the patient affording for the newer molecules. We can try with this multi-tyrosine kinase inhibitor, that is a lenvatinib. Then in 2020, we saw the RET fusion inhibitor selpercatinib, followed by in 2021 cabozantinib and the pralsetinib in 2023. And the rest we have now, there is a role for immunotherapy as well. So those are the different drugs. So whenever we talk about principles of kinase inhibitor therapy in advanced thyroid cancer, so what do we have? So we have this oral tyrosine kinase inhibitor which have demonstrated clinically significant activity in randomized trials, but all these trials are versus a placebo. So again, I am reiterating, it is in a locally recurrent, unresectable and metastatic either medullary thyroid cancer or radioiodine refractory differentiated thyroid cancer. So these are the subsets where these tyrosine kinase inhibitors are recommended. And again, treatment has to be individualized. This is when I tell giving tyrosine kinase inhibitors is not very easy. It can be patient-centric. We need to consider several factors, underlying comorbidities, especially cardiac, because the anti-VEGF or multi-tyrosine kinase inhibitors are cardiac toxicities also. So we have to rule out in an underlying patient any significant cardiac comorbidity, organ function, because most of the drugs get either cleared by the liver, most commonly the liver, and later by the kidney. So they have to have a preserved organ function, or we need to modify the dosages if they have any borderline dysfunction of kidney or the liver, and concomitant drugs. This especially again becomes important with in multi-tyrosine kinase inhibitors with anti-VEGF action, because they also can cause QT prolongation. So if they are taking some cardiac drugs or some commonest antibiotics when you prescribe, or some psychiatric drugs which can cause QT prolongation, we need to be mindful of the fact that these can also cause QT prolongation. And this I already discussed with you, the pace of disease progression should be factored. It is not that all patients who progress need therapy. It can be either an indolent progression with no effect on the patient's quality of life, or a rapidly progressive disease. So rapidly progressive disease may benefit from the tyrosine kinase therapy. And optimal management of kinase inhibitors side effects is essential. This is where we need to have knowledge now with approvals of new molecular pathways, new drugs for each of these targets. We really have to read up and know when we are prescribing the drug. So guidelines outlining the management of the most commonly seen dermatological toxicity, hypertension, gastrointestinal side effects should be known. And some of the side effects, if ignored, can be fatal, especially GI perforation. And in addition, we need to dose modify. Sometimes it requires dose holds and restarting, and also a permanent discontinuation of the drugs as well. So molecular testing, this I already emphasized. In the era of tyrosine kinase inhibitor, it is beneficial to make a targeted therapy decision for drug therapies or clinical trial participation if you need to refer the patient to other centers with active drug accrual. And in addition, the presence of some mutations may have prognostic importance, like the red fusions in medullary thyroid cancers, where patients do behave well. And this is the present NGS test panel that we all have to test as prescribed by NCCN and ESMO guidelines as well, where we need to check for ALK rearrangement, BRAF V600E mutation. It is not the complete panel of BRAF, it is the V600E mutation, red fusions, NTRK fusions, and as for amenable for immunotherapy, the NGS should empanel MMR and TMB as well. So all these can be tested by a broad NGS panel, or we can specifically do FISH or PCR panels based on the institutional preference. So this is a slide which shows what drugs we have approved, what targets they actually work on, and what are the efficacy of the results that we have. So initially we had this sorafenib. Sorafenib is a good old drug, but lot of hand-foot syndrome and what we called as palmoplantar dysesthesias. It is now out of practice because of the same once lenvatinib came in. So it is a multi-tyrosine kinase inhibitor which has vascular endothelial growth factor receptor, platelet-derived growth factor receptor, and a RET fusion inhibitor. Approved again in a radioiodine refractory differentiated thyroid cancer. It was tested against placebo with a meager response rate of 12% and a PFS of 10.8 versus 5.8 months. Next, we have the lenvatinib. Again, it is a multi-tyrosine kinase inhibitor approved in the same setting, the radioiodine refractory differentiated thyroid cancer. Very good response rate of 65% and a median PFS of 18.3 months versus 3.6 months against placebo. So then we have this vandatinib and cabozantinib. Both are approved for radioiodine refractory DTC when progressed on first line sorafenib or lenvatinib, that is cabozantinib, and vandatinib is approved only for medullary thyroid cancers. Again, they are multi-tyrosine kinase inhibitor. In specific to VGFR, they have action against RET as well, RET and MET as well. So they again were compared to the placebo. So we have very good response rates, especially in RET fusion positive with 30 to 45% response rates, and a PFS of around 11 months versus the placebo. And cabozantinib, I said, is in the second line setting, again with a very low response rate, which all means that the first line is what is very important. Why these targets are important? Because again, these targets determine the toxicity profile of these individual drugs as well. Coming to the second class, BRAF or MEK inhibitors, we have dabrafenib plus dabrafenib and trametinib, which is approved. Dabrafenib is a BRAF inhibitor and trametinib is a MEK inhibitor. Initially, there was use of single agent dabrafenib, but they started noticing a lot of skin toxicities, including squamous cell carcinomas of the skin. After which, the most of the approvals are in combination with a MEK inhibitor. So again, they are approved for BRAF mutated anaplastic thyroid cancers and BRAF mutated radioiodine refractory differentiated thyroid cancers. So with a very good response rate of 56% in ATC, a very good figure. Median PFS of just 6.7 months though, knowing the histology of the aggressive histology of anaplastic thyroid cancer. And the single agent approval is also there, but now we are almost always dependent on dabrafenib and trametinib. In radioiodine refractory setting also, it can be given in combination with a response rate of 30% and a PFS of 15.1 months. Then we have the NTRK fusion inhibitors. We have larotrectinib and entrectinib. which are recommended for NTRK fusion positive thyroid cancers, irrespective in this setting. Most of them will be radioiodine refractory thyroid cancers. It can be either differentiated or anaplastic, or all of these can have NTRK fusions. So again, in differentiated thyroid cancers, the response rate is 78% with a median PFS of 48.7 months, and in anaplastic, a response rate of 14% with a PFS of just 2.2 months. And these two drugs almost behave the same. Then we have the selpercatinib and pralsetinib. Pralsetinib was a recent inclusion again for RET fusions and RET fusion mutated medullary thyroid cancer. This is the most commonest approval they have, and any other thyroid cancers with RET fusion positive they can use as well, with a response rate anywhere between 70 to 80% and a median PFS of 23.6 months and around 20 months in both different types of cancers. So coming to tell about now, going more in deep towards these tyrosine kinase inhibitors, the mechanism of action. We all saw the molecular pathway. In the spectrum of selectivity, we have multi-tyrosine kinase inhibitors. We have multiple targets, the VEGFR, FGFR, EGFR, and the MET, and the kinase inhibitor specific ones, that is the RET, or we have this dabrafenib and trametinib, which are specific for RAF pathways. So all downstream kinase pathways are the same except for the VEGFR, which acts in a different way. So coming to the topic of interest today, that is the adverse effect of multi-tyrosine kinase inhibitor. I already told you it all depends upon the group action, that is where the molecular pathway that it acts into. So considering these multi-tyrosine kinase inhibitors which have anti-VEGF action, most of the side effects are because of anti-VEGF action here. We have lenvatinib, which is dosed at 24 mg OD, but rarely we reach up to this dose. We usually start by 12 mg with incremental 4 mg increases, and we maximum reach up to 16-20 mg in individual patients. They do develop severe hand-foot syndrome, mucositis, and that is where it becomes dose limiting for us. And in severe renal and hepatic impairment, we need to again watch out. The dose modified is 14 mg once a day dose. Sorafenib is 400 mg BD. Cabozantinib, again based on the BSA, either it is 40 or 60 mg, and vandatinib is a 300 mg OD dose. So the commonest toxicities that we face with TKIs, cardiovascular, so hypertension and hypertensive crisis. So we need to constantly check on patients for BP, the blood pressure monitoring, prior to treatment, during treatment. If they're if they are on the regular antihypertensives, we need to optimize the dose. For grade 3 hypertensions, we need to withhold despite optimal antihypertensive therapy, and grade 4 hypertension calls for discontinuation. Cardiac dysfunction, clinical symptoms we need to monitor for signs of cardiac dysfunction. We also have an institutional policy of routinely monitoring these patients with a 2D echo every 3 months. Most commonly they cause left ventricular dysfunction. They can also cause right ventricular dysfunction, cardiomyopathy, and heart failure. Grade 3 cardiac dysfunction we need to withhold or discontinue, and for a grade 4 cardiac dysfunction we need to permanently stop. Arterial thromboembolic events. In a patient who is on these tyrosine kinase inhibitors developing an arterial thromboembolic event, that is a myocardial infarction or CVA, we need to permanently stop. And the safety of resuming this anti-VEGF tyrosine kinase inhibitor after such an episode is not being studied. So more so, it is not safe within the 6 months, but after 6 months to restart or not, or initiate, it is subject to individual physicians' experience. Then we also have this QT prolongation, which can go up to torsade de Pontis, ventricular tachycardia, tachyarrhythmias, and fibrillation. So what we need to do is serial ECG monitoring. We have to correct the electrolyte abnormalities which can cause prolonged QT. The calcium, potassium, and magnesium becomes important. We also know that tyrosine kinase inhibitors cause hypocalcemia, and the QT interval more than 500 milliseconds withhold, and more than 60 milliseconds increment from the baseline QT for a patient. Then also calls for withholding. Regular ECGs have to be monitored, and be careful when we prescribe concomitant drugs which can also prolong the QTC. The reversible posterior and leukoencephalopathy syndrome, which is usually seen in our setting, I've encountered patients who are on these tyrosine kinase inhibitors who come with accelerated hypertension, and then they go to something like an encephalopathy, and the radiologist gives us this kind of report. So in such patients, we have not re-challenged, but again the recommendation says withhold till fully resolved and control the hypertension. Hemorrhagic events, withhold or discontinue based on severity. Renal failure or impairment. They can cause grade 3 or grade 4 renal failure, withhold or discontinue. Monitor proteinuria. This is again regularly to be monitored as per the product description for this anti-VEGF tyrosine kinase inhibitor. And more than 2 grams per 24 hours proteinuria we need to withhold. And for a nephrotic range proteinuria, that is more than 3 grams per 24 hours, we need to permanently discontinue. Gastrointestinal toxicity. Diarrhea can be severe recurrent. This is one of the, apart from the hypertension, this is the second most common toxicity that we see, diarrhea. We have to be very, we have to give a prescription afferent only to the patient to have anti-motility drugs with them, and withhold or discontinue based on severities, based on different rates of dehydration requiring hospitalization. The diarrhea is graded. And the second gastrointestinal toxicity, very rare, is fistula formation and gastrointestinal perforation in patients with pre-existing diverticulitis or a recent surgery for any other problem. So discontinuing patients with grade 3 or grade 4 fistula or any grade perforation, it calls for discontinuation. The third most commonest we see is the the second most commonest we see is dermatological toxicity after hypertension, hand, foot, skin syndrome, that is palmoplantar dysesthesia. They can be just simple rashes and can be as severe as Stevens-Johnson's or toxic epidermal necrolysis, which is a exfoliative and dermolytic reaction, and this calls for permanent discontinuation of the drug. This depicts, they can just present with this tips as redness. We usually prescribe them keratolytic agents and some kind of steroid supplements. It can also go for something like a bullous type of reaction followed by peeling of the skin. And it will be so painful that patients would not be even able to ambulate with such toxicities. So what are the other toxicities? Impairment of thyroid TSH suppression. It is very important because this has to be monitored again. Hypocalcemia, I already covered. Osteonecrosis of the jaw. All anti-VEGF agents can cause osteonecrosis of the jaw. So prevent your dentistry and make sure that you do not do invasive traumatic procedures, dental procedures when the patient is on TKI. Adrenal insufficiency, especially if a patient has persistent hypokalemia, fatigue, it is one of the rare toxicities. And especially in a young patient, embryofetal toxicity, effective contraception has to be advised. Impaired wound healing. This is one of the things that I wanted to highlight, especially because it's a surgical talk. So, we also delve into patients who undergo recent surgery for other indications like a RCC when they come post-surgery for a cytoreductive nephrectomy and for a tyrosine kinase inhibitor in adjuvant setting. So at least 1 week before an elective surgery, these tyrosine kinase inhibitors, especially the multi-tyrosine kinase inhibitors with anti-VEGF action, has to be withheld, and at least 2 weeks following a major surgery or adequate wound healing, we are not supposed to restart. This is again because it can delay the wound healing process. And also in certain reports, what I was reading is in anaplastic thyroid cancer, which is locally quite aggressive and infiltrating the surrounding structures, it can also cause bleeding. So last of the toxicities, hepatotoxicity. Monitor liver functions, monitor withhold or discontinue for grade 3 or grade 4, and in hepatic failure, discontinue. So when this is one of the checklists that before anti-angiogenic agents is a relative contraindications. Relative means they are not like absolute, but you need to be careful that patients can go for such complications and be watchful. Poor cardiac function or recent MI, uncontrolled hypertension, large unhealed wounds, history of colitis, diverticulitis, intestinal perforation, or a recent bowel surgery. A tumor invading trachea, esophagus, or great vessels. This is an anaplastic setting. And hemoptysis or use of anticoagulants because they are more prone for bleeding here. And very low body weight because some of the drugs have body weight, body surface area recommendations for use of the drug. This just incorporates everything what I told you, head to toe. It is just for ease of information. We have thyroid, bleeding, GI, that is diarrhea, and the cardiac side effects, hypertension and thromboembolism. So RET inhibitors, when we come to RET inhibitors, we are speaking about sulfatinib, pralsetinib, which are selective RET inhibitors. They have a different set of toxicity, and cabozantinib and vandatinib, they have anti-VEGF as well as RET toxicity. So they can cause hypersensitivity, cutaneous rashes and reactions, stomatitis or dry mouth, edema or chylous effusions. They can present with fluid retention syndromes. So in that case, whether disease progression or it is a drug toxicity has to be kept in mind. One of the complications of these RET fusion inhibitors is pneumonitis or ILD, which can be fatal if not picked up. Hematological, they can cause neutropenia. Fatigue, hepatotoxicity is known, and because of anti-VEGF action, they can also cause all these cardiovascular effects which I covered priorly, delayed wound healing, and rarely these RET fusion inhibitors can also cause tumor lysis syndrome, More so in aggressive histologies, rapidly progressing histologies, when you try to take care of the tumor with a systemic therapy, they can also go for a TLS-like picture. So this is just a capsule of it. So you have musculoskeletal, the rashes, more commonly the skin toxicities, pneumonitis, and the cardiovascular and GI toxicities. So selective RET inhibitors, specific mention of ILD, this is the one which is additional, and hematological toxicity, that is the cytopenias. So in case of this one, BRAF or MEK inhibitors, the recommended combination is dabrafenib and trametinib with V600E mutation. And BRAF inhibitors, especially when we are talking about monotherapy with BRAF inhibitors, they exclusively cause skin toxicity. So rashes, then musculoskeletal, arthralgia, fatigue, pyrexia is known. We have to give specific indications for use of paracetamol or acetaminophen. Excessive sensitivities to sunlight, hyperkeratosis, dysesthesias, and this is the one which I was highlighting. They cause paradoxical activation of the MAP kinase pathway and development of secondary cutaneous squamous cell carcinomas and keratoacanthomas. That is how BRAF inhibitors alone fell out of place, and that is when now we prescribe it always with MEK inhibitors. They also can cause alopecia and QTC prolongation. So if you're talking about MEK inhibitors, they in addition cause GI toxicity, diarrhea, nausea, vomiting, cardiotoxicity, LV dysfunction, ocular iritis, uveitis, and pneumonitis. So this is again a capsule. You have fever, eye toxicity, lung toxicities, cardiac toxicities, and GI toxicities. The NTRK fusion inhibitors, we have entrectinib and larotrectinib. So what is NTRK? NTRK is a neurotropin tyrosine receptor. So all the toxicities that we see with NTRK fusion inhibitors are on-target effects. So on-target effects means it is most of the things concentrated on the normal CNS. So they present with dizziness, ataxia. In patients who progress on an NTRK inhibitor and you withdraw the drug, they develop a severe withdrawal pain, cognitive dysfunction. They also have weight gain, dysgeusia, GI side effects, arthralgia, and neutropenia. So this is what it means. These are special toxicities, CNS directed, because of the specific tropism, the receptors being expressed in the CNS as well. So these are all on-target side effects they call. So what is the take-home message? Especially for a medical oncologist who deals with referral for tyrosine kinase inhibitor, watch for toxicities, grade them, manage for drug hold or dosage modifications appropriately. In a perioperative setup, look for wound healing, bleeding complications, especially in anaplastic variant which has rapid growth with local infiltrations. Use TKI judiciously when indicated, and also do a NGS test platform for a targeted approach. And there are also new therapies which are coming, combinations of TKI with immune checkpoint inhibitors, and we need to see how they behave with respect to patient benefit. Thank you.
Thank you, Dr. Sandhya, for the exhaustive complications following TKI use. Any clarification? Anyone want to make a point?
Very interesting talk. So I have a fair experience of using these drugs in anaplastic and poorly differentiated. And as you rightly said, none of the patients go up to 24 milligrams for lenvatinib. But it is the most commonly used drug in my practice also. But all the time you have to decrease the dose, and you find that anaplastic or poorly differentiated grows back again. So it's a very, very difficult. These are very difficult drugs. Difficult when to start and when to stop. That's the thing. So just wanted to know if have you used cabozantinib, and how do you think it has less side effects than lenvatinib?
So cabozantinib, we do not have experience in thyroid, sir, but we have experience in RCCs. They are much more tolerable than lenvatinib. But again, because it's approved in thyroid in second line, most often when a patient progresses with lenvatinib, the challenging of therapy is itself difficult because it's a very rapid progression for us.
So can we use it as a first line rather than using lenvatinib?
So I was just checking for the literature support, we do not have first line approval, sir, for cabozantinib.
So off-label use we can perhaps...
Might be, but again, because all of us have wetted our hands more with lenvatinib, it is the favorite drug prescription. And in patients who have responded, they have a consistent response.
They have a good response.
Yes,
I had a patient of poorly differentiated who survived for 2 years just on TKIs.
That is how it is, yes.
But it produces a good quality of life. Patient can swallow, eat normally, the dizziness gone. So the quality of life tremendously improves with TKIs.
Yes.
And do we have these selective inhibitors available in India? Not yet.
None of them, sir, except for the immunotherapy which is readily available. All of them need to be imported.
Thank you.
So we have some experience of using lenvatinib as a neoadjuvant, even in, I mean, the current indications were for radioactive iodine refractory. So we are using this as neoadjuvant. And the typical starting dose is nowhere near the full dose, but we get a good response after 8 to 10 weeks. We stop the drug for 2 weeks and then we go ahead with surgery. Our indications are R2 resections where it is anticipated. We've operated 6 patients until now. What we've, as you also said, that these are agnostic to particular molecular alterations. So we in fact start them without doing an NGS. But while I was going through one of your tables, I found that with larotrectinib, the median OS or PFS has not been achieved,
Yes.
and it's 74 months. So is that are we missing out on a great drug for some cancers where that mutation might be there?
Yes.
Because amongst all these drugs, the stupendous PFS survival is
So
there.
definitely, sir. But again, we do not have real-world experience on these drugs because of lack of feasibility of use.
Is
That is where it comes.
larotrectinib available in India?
No, sir, it is
No, not
not.
available.
It almost costs around 8 lakhs per month.
Yeah. So the advantage of Lenvima is the cost, of course.
Yes. And now that we have the generic molecules as well,
Yeah.
it is quite easy access for the patients.
Yeah.
Can I ask you, have you found any difference between the generic and the Lenvima original research model? Efficacy and side effects?
No, sir, because whatever we are using, the generic molecules are also are of standard Indian companies. More so, they are almost the same, sir. Even with respect to toxicity, the expected toxicities, they develop this kind of difficulty in swallowing, voice change, then oral mucositis, hand-foot syndrome, almost the common spectrum.
Just one more thing. When would you want to stop these drugs before taking up for a surgery?
So that is what I covered in one of the slides. As per recommendations, it is 1 week prior to a major surgery and 2 weeks later on. But again, individual discretion, when we talk about in RCCs and all, when we have rarely used, we do discuss with the surgeons. When it is a major surgery, they ask us to stop for at least a month. So it is a individual discretion on your surgical thing as well.
So this is for other seniors. So if suppose like ma'am started with ATC locally advanced, and then we have started on lenvatinib, there is a response. So how many days do we want to stop? Because we know that the moment we stop,
It
it
grows.
grows.
As soon as you can start back,
So
you know,
2 weeks
so-
is what we've done. We've only operated 6 patients, but we've maintained
In
meticulous
ATC
data.
also, sir.
Huh?
In
8,
ATC.
no, not in ATC. We haven't done operations.
ATC is only for palliation. It's poorly differentiated or advanced DTCs or aggressive DTCs.
Poorly differentiated tall cell variants.
But that window is very narrow. I've tried only in 2 patients. Luckily, we got a window and operate. But that window can go away very quickly.
That's right. So, a question for you and then for her. First for you is if there is a response in ATC, if it was inoperable before, would you consider surgery if there is a response? Because
No,
many
no.
a times they will respond to the lenvatinib, or to the targeted therapy.
Non-metastatic.
Non-metastatic.
No, ATCs I don't operate. PDTCs and DTCs I operate.
But if you look at the latest ATA guidelines, they
Yeah.
will recommend that
So-
Yeah, but unfortunately, it's very difficult to get that
Yeah.
particular patient.
response.
Yeah,
Yeah.
more so the literature says in anaplastic the most common is BRAF. So we have to use a
Yeah.
BRAF inhibitor which is a very high response rate.
Yeah.
Yeah.
And question to you is, have you ever tried immunotherapy or combination of immuno with enva in these situations?
No,
With
we
enva?
haven't.
So here's the funny thing also with the neoadjuvant use of lenvatinib. We've used it in 2 poorly differentiated, and on final histopathology they were well differentiated. So obviously any thyroid cancer, at least the follicular derived, will have a spectrum of the cells, and lenvatinib is killing obviously the most de-differentiated cells. So what remains or what does not respond to that treatment is the differentiated type. So this is what we've seen in 2 of the 6 patients we saw.